Good day, everyone, and thank you all for joining us. My name is Nick Armstrong. I'm the Managing Director at the Institute for Veterans and Military Families up at Syracuse University. Welcome to our webinar on the expansion of navigation systems supporting the access of social care and services in communities. Before we dive in, some quick background on the IVMF for those who are new to us. Based at Syracuse University's National Veterans Resource Center, but operating globally with more than 100 professional staff, the IVMF delivers programming in career, vocational, and entrepreneurship education, offers and supports community-based services across the country, and provides research, program evaluations, and data solution support to public, private, and social sector organizations at all levels. We serve about 20,000 military-connected individuals annually and have served over 150,000 in the last decade. But central to what we do is bridging and translating research into practice. Bringing insights from experts to advance how we serve those who have served. And today's webinar serves this very purpose. Service navigation remains a central challenge for veterans and military families. It's really, what started our involvement in this work more than 7 years ago, alongside our community partners. And you could argue that the veteran community has been out in front on this particular issue in particular. But it's also a challenge for many other populations across the country. And both the marketplace, industry, and even national policy is changing quite rapidly, supporting greater access and support to address the social determinants of health. So it's important that we, those who serve veterans, continue to start looking outside our own bubble in terms of what we do to serve and support the military community. And that's why we're delighted to bring two of our good partners who've been doing exactly that, to share more on a case study of the changing landscape of navigation systems in Pennsylvania, as well as some of the broader trends that are seeing both in the marketplace and in the policy sphere. And so with us, we have Dr. Michelle Shumate, Professor of Communication Studies at Northwestern University. She's also the founding director of the Network for Nonprofit and Social Impact. As well as Megan Andros, who's an Army veteran, senior program officer at the Heinz Endowments in Western Pennsylvania. And she's also a fellow at the Hoover Institute at Stanford. And with that, I'm actually going to turn it over to my close teammate and IVMF Director of Evaluation and Capacity Building, Gilly Cantor, who's going to facilitate this discussion. So with that, I'll hand it over to Gilly.
Thanks, Nick. I am going to turn it right over to both of our main speakers to do a little bit more around introducing themselves, and especially because they both do quite a lot of things, talk about specifically the work that they do related to the topic of our webinar and kind of what brought them to focus on this particular topic. So I'll start by passing it over let's start with Megan.
Thanks, Gilly. It's great to be here today. Thanks for the invitation. So I'm a senior program officer at the Heinz Endowments, as Nick mentioned, and we have a history, an 8-year history now at this point, of serving military veterans. We have strategically focused on prevention, post 9/11 veterans, and transition from the service to the community. We feel like our role as a foundation is to help sort of innovate on what develop better solutions that drive better reintegration outcomes. And how I got connected to the topic of navigation is we very early on and in some part based on my own transition from the service, recognized that folks were leaving the service, moving to Pittsburgh, and needing access to resources preventively, sometimes retroactively, right after they experience a problem. But we didn't have a great solution for how to connect them, and so turned to you all, actually, I think more than 6 years ago at this point, to help us develop PA Serves. Our network's been up and running now for 6 years, and I know, just on sort of a personal note, as a program officer, I used to get calls from veterans every once in a while saying, hey, I need this or that. Can you help me? I Googled your name and I found you. And I used to say, well, good luck, call this number. I hope you get where you're wanting to go. But, 6 years later, I'm really confident now that I can say, call PA Serves. And we've got the data to understand how people do when they get connected, how long it takes. So I've stolen a term from you, actually, Gilly, that I am an accidental expert on navigation at this point, after having sort of been connected to this network that we run in Pittsburgh for the last 6 years. Let me know if I missed anything there, but I will stop at that.
Thank you. And over to you, Michelle. And sorry about the screen share before, guys.
Sure. So I think that I first really became involved in thinking about navigation networks with research that we had done in an NSI around education. So one of the things that we found early on was some of our most effective education networks who are trying to improve education outcomes were doing really continuums of care. They were beginning to think about how do you get navigators into families that were struggling, and how do you provide more than just better teaching in the classroom? How do you address the full set of social needs that we know are really related to education outcomes? As a researcher, I've been involved in studying networks for a long time, but this intrigued me. And then when I got in touch with Nick and Gilly through a colleague at Syracuse who introduced me to them, and I learned about America Serves networks. And so I've been working with the folks there for about a couple years now, looking and evaluating how do we understand the effectiveness of these networks? What are the practices that really promote greater effectiveness? And then more recently, how do networks respond to challenges, particularly COVID? How do we understand how to build networks that are resilient to being able to have not only changes in the number of requests that they're receiving, but really the vast distribution of those requests. We saw a lot of networks have a drop, for example, in housing and employment assistance requests, but an increase in food service requests. So how do you make sure that we build networks that are resilient? And then that led me to get to know Megan and to try to understand what was going on in Pennsylvania. And the more that I've peeled back the layers around navigation network, the more that I've come to see what's happening in the veteran space and the education space as part of the small kind of landscape that's going on around navigation more broadly, both from an understanding of what's happening in practice and communities, but also some of the shifts that are going on around navigation in the policy arena that I think that veterans organizations in particular need to be aware of.
Michelle, I think that's a really good segue also to help kick us off by having Megan, if you can speak to what led to you and the endowment commissioning this report from Michelle. I know you talked about PA Serves. I know, we've been experiencing a lot of what Michelle writes about, but kind of what led to wanting to study this a little bit more formally.
Sure. So in my role at the endowments and responsible for our veterans and military families grant making, I'm actually part of the community and economic development team, which has a broader mission. And we have grantees that are outside of the vet space under that umbrella. And we started hearing from them that they had, for example, clients that were in housing crisis, and they were trying to get them into certain programs or relief, or maybe rent relief, or maybe an emergency sort of stipend to help them stay in their homes and pay a month or two's rent, and that they were having a hard time making that happen. So they were trying to connect to resources in our community, but they weren't doing it effectively. It wasn't working. They were spending almost more time on things other than what they were an expert at. So, an organization that was trying to pull people out of poverty, by getting them workforce training and, taking care of the childcare for the family, they ended up doing everything else and not able to really focus on their mission because they weren't trusting other organizations around them. So we were hearing that was a problem. And then we started actually receiving grant requests from organizations asking for funding to do for technology for them to serve as almost service navigator organizations. And it was a bit of a moment. I think, two things were happening. One was we had a history of investment in PA Serves, and we had an understanding of what was happening within that network. And so on one hand, we thought like, well, we have an example of a network that we feel like when referrals are made, we know what happens. We feel good about that. Why isn't that happening outside of the vet space? And then the second thing that I think happened was we had to stop and take a look at ourselves and try to sort of ask the question, what is the appropriate role for the endowments given what we're seeing and hearing from grantees? And right off the bat, we understood we can't have multiple networks. We were already aware of 3 navigation networks. What we didn't want to do was support a network of creativity of artists, right? Or support a mental health network, support a housing network, support a, you name it. We figured that we needed to stop and sort of ask deeper questions about where the space was heading and the right role for the endowments to play, given the confusion and the complication of getting a person to a resource in a sort of limited amount of time and then understanding how they did. So that's when we turned to Michelle, and thanks to you all, we were introduced. So with that, I'll end.
Thank you. And I think I remember that you were feeling surprised that initially after, working with PA Serves for such a long time and being thoughtful about not perpetuating more confusion in greater Pittsburgh. And so I think with that, we can turn it over to Michelle to talk a little bit about the framework that she used in this report and how I think it applies much, in our observation beyond, and hers, I think beyond just Pittsburgh and even Pennsylvania. And it seems to be a trend that we're seeing, which is part of the reason why we're all here today. So Michelle, if you want to get started, I'll pull up a few of those slides while you're getting started.
Sure. So one of the things that I think makes understanding the landscape of navigation networks challenging, and one of the first problems I had to solve in creating this report, was that people didn't have a common understanding of what we meant by navigation. Like some people, when I would say navigation networks, would say, yeah, we do navigation. Here's the PDF we hand to everyone that has all of the different resources and places they could go. And that is navigation in some ways, in a very limited form. But then when we compared that PDF to what would happen at a PA Serves, for example, where you have a more robust coordination system, it didn't really seem like we were talking about the same class of navigation, right? Like it was different piece. So we had to start with defining it. So throughout the report, we talk about navigation systems as organizational arrangements primarily. They're about relationships between different agencies, nonprofits, and in some cases, businesses trying to help individuals locate and obtain valuable benefits, programs, and services. And what's important about this definition, about understanding it as an organizational arrangement, is then there are 3 different pieces that can help support those organizational arrangements or components. And many times when I was talking to navigation networks, the piece that they would highlight was, oh, yes, we have a technology. We use Apricot. We use Unitas. We are Aunt Bertha Network. We've created our own set of technologies out in Salesforce. And they would tell me primarily first about their platform. But I found that actually hid some of the differences between these navigation networks, because different navigation networks were using these platforms in different ways, right? So there were 2 other components that I think are really important to understand as we differentiate between navigation systems. The second piece is human navigators, which is what role do individuals play in getting those who are seeking help to the help they need, right? And there's a bunch of different ways that human navigators can enact change. They could be call center employees, right? So 211s around the country have call centers where people call in. Those call center operators are human navigators. They play a very specific role. There are, throughout the country, recently community health workers and community resource advocates who go out into the community and they work with individuals, helping to identify needs even before somebody might ask, right? That's a different model of a navigator. And so that's a component that differentiates networks. And the last piece is intervention type. And so Gil, if you can go to the next slide around intervention type. What I mean by intervention type is that sometimes networks are designed to help an individual get all the way to the finish line from identifying a need all the way to receiving that need. So for example, PA Serves operates in that way, right? Where they have coordination center employees who work with veterans to identify those needs, and then they take them all the way to ensuring that there is services rendered, right? Like the continuum. There are other networks that don't do that, that just focus on one step of the help seeking process. They might just focus, for example, on providing that number that Megan was alluding to earlier when she got calls. And that's where this really stops. And so that's a differentiator. So the report ends up talking about 4 different types of navigation networks, and that's the next slide, Gilly. So the first one is what we call community connectors. And those tend to be local community-based navigations that take a client-centered goals approach. They lean really heavily into the human navigator investment, but they tend to be very light on the investment in the technology systems. And so they might not have the capacity to track outcomes. A second piece might be, a second type is demanded directory. And a demanded directory really invests heavily on developing that resource guide. And really human navigators are primarily just involved in matching the client to the services that are provided. They only focus on that limited aspect of the intervention. The new and probably fastest growing sector of navigation designs are the healthcare developers. And we'll be talking more about that later in the webinar about why this is occurring. But there is significant investments from hospitals to both screen individuals for social needs and to refer them to different human service and other agencies to meet those needs. And so that became a third class of navigation designs. And then last word is really what we call system integrators. And system integrators tend to take a no wrong door approach. They have more robust referral systems and data systems. And then they're able to look at the person and help them all the way across the finish line in terms of a help seeking intervention. So none of these are the best, right? The only way to do navigation. I'm wondering, from those of you who are on the webinar, I don't want to just talk at you. I'd love to know which of these navigation designs, if you are involved in a navigation network or providing navigation, most resembles what your organization takes a look at. And I'd love for you to share that with one another in the chat. I think that would be really helpful. The last thing I want to highlight in the report is the different types of metrics that individuals use. And I think that's the next slide, Gilly. So there are different kinds of ways to evaluate whether the navigation system is performing the types of services in identifying help seeking and helping people cross that finish line. And so you should just be aware of these metrics. We're going to come back to them again later in the webinar, especially around policy. So first one's quality control. Those are by and large call center metrics. So looking at, looking at the conversations, doing client audits of the different interactions, trying to understand, was that interaction with a human navigator meeting the criteria of what's good design? Second one's demand. That is, what are people asking for, right? And so getting a distribution of that can be really helpful in a geography because it can help people like Megan or like city and county government or like the state decide where they need to invest more dollars. Supply is the flip side of that. So do we have enough capacity to really meet those needs? Or is that one of the reasons why people are seeing a wait list or are not getting their issues resolved? Fourth class is referral process, which means how fast did the person get a match? How fast did that service get started? And what percentage of those were actually closed? Did they close the loop on those pieces? And then the last piece, which is going to become increasingly important, is social impact, which is the ability to show that the navigation network was able to produce outcomes for clients and for organizations that they could not have achieved without the navigation network. So here we're looking at things like return on investments for healthcare developers. Are they seeing a lower cost of care, fewer emergency room visits? Are we seeing greater wellness and financial security for clients, right? That's the kind of social impact that we're after. So that's a high-level review of the report. It's the most talk I will do during this webinar for those of you who are listening, but I think it might help give you a preview of some of the things that we're going to be discussing so that you can get your hands around this landscape of navigation systems that are out there and the ways that policy is now going to be pushing certain types of designs over others.
And I think there are some questions or comments coming in that we can come back to at the end around how communities see themselves fitting into the framework, or how maybe some questions about how to figure out where you fit into this framework, or what might dictate which type of approach is right for your community. So I think we can come back to some of those. But I think first I want us to zoom out, and unfortunately, sorry, Michelle, ask you to talk just a little bit more about some of the broader trends that are going on in the federal policy landscape, particularly around social determinants of health, this topic of service and navigation care coordination, and technology. What do you see right now as being the major developments, and who's driving those developments? What are the funding implications? How do those differ by states, communities? I just asked you a lot of questions, but I'm going to go to the next slide here where we have a little bit of a timeline to talk through, but then just, I think in putting that in context of where these conversations are coming from and where they're going.
Yeah, and I think this webinar is really timely because this is a fast moving policy landscape. So some of the investments in navigation are long-standing. So areas on aging dates back to 1974, and areas on aging have tried to coordinate care for seniors in the United States since that time. Because it's so long-standing, they've got great evidence of outcomes, and that's one of the reasons why we continue to support areas on aging. Results suggest it's a little bit under $150 per person who receives navigation savings per year. And so there's really good evidence to continue building on this trend. Second kind of policy move was around housing and really trying to address chronic homelessness in the United States. And so one of the things that the federal government worked on was developing continuums of care. Continuums of care mandates that housing agencies in a particular geographic area as predetermined will come together in a network and do this navigation, making sure that you can get individuals with the highest needs into housing services. Again, we've got some really good evidence that continuums of care work. In fact, we can demonstrate now that they do reduce chronic homelessness in the United States and when they work where they exist. So we've got really good trend evidence now on that. So all of that success has gotten people thinking in other areas about what additional investments might be made. And one of the places that is really coming to into a kind of policy framework is coming from the Centers for Medicare and Medicaid. Some of this was created through the Affordable Care Act, which mandated that hospital systems had to make referrals to social services. It's part of the requirement now written into the IRS code for them to remain a nonprofit hospital, that they provide those services. And so there's actually teeth to this regulation in terms of being able to maintain your nonprofit status. That has then, building on that mandate, now there are a variety of different opt-in mechanisms that different states or localities have provided, come into, including delivery system reform incentives, Medicaid 1115 waivers, and the accountable care organizations. All of those are really designed around, one, moving Medicaid money to actually pay for the social determinants of health, so they can pay for food and housing and employment assistance, and increasingly also care coordination. And so for states who have opted to take these waivers, part of this is the financial implications of where that money goes. But the second piece of this is really around thinking through what's the required data to support this. And from CMS, the required data, especially coming through the 115 and accountable care organizations, is can you demonstrate that this is not adding cost and in fact is a cost reduction measure? They are firmly committed to an ROI in terms of reducing the cost of Medicaid through this strategy. So you have to have, ultimately the states and localities who are opting into this measure have to have systems that can track whether or not that their systems are producing a reduction in cost. There are, even most recently, CMS has this roadmap to the state's guidelines about how to use these waivers and what's allowed. I'd highly recommend that as a document to take a look at and to see where policy is heading. Right now in committee is the LINKed Act. The LINKed Act just made it to House committees 2 weeks ago. And this is a new initiative that you should be aware of. It's big money. Currently, the bill, we don't know what it will finally have, but right now the bill as written is talking about investment to the tune of $150 billion over 4 years. What's unique about the LINKed Act is it's not being driven by CMS. It's not a healthcare pool. The LINKed Act equally positions health and human services providers together so that the act is requiring evaluation not only in terms of improved health, but also in some of these economic measures around reduction in poverty, increased client well-being. So it's not just interested in ROI in terms of healthcare costs. It's a broader bill, and it's worth taking a look at. There is already a version that was sent to committee in the Senate back in March. So this has been around for a while. And there seems to be some momentum there. I know that the Hannon Act is also part of this topic, but I am not the expert in the room when it comes to Hannon. So I want to actually ask my colleagues at IVMF to talk a little bit about Hannon and particularly Fox grants.
Sure. So, and I'm also not an expert, but we do know a bit more about this legislation than some of the broader legislation because it is specific to veterans. And I think a lot of people, as a result, on this webinar today are likely a little bit familiar with it. But just to set the stage for it, this is officially named the Commander John Scott Hannon Veterans Mental Health Care Improvement Act. So a mouthful, but it was bipartisan legislation that was passed in August of 2020. And its focus is entirely on improving veterans' access to mental health care. And it's very, very comprehensive in its approach. It does all kinds of things like increase the workforce dedicated to mental health within the VA, including adding suicide prevention coordinators at every VA medical center. It allows for exploring other new treatment options and incorporating those into treatments, expanding telehealth and other options for people that live in rural areas or that are generally harder to reach populations. It adds some measures of accountability to the VA for this work. And then then the biggest kind of piece that we wanted to mention today was specifically the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. So I will just be calling this the grant program because, again, another mouthful. And I should say that both that program and the bill itself were named for 2 service members who died by suicide within the past 3 or 4 years. And so it's a very, very well supported set of measures taken together from both sides of the aisle. And this program in particular would focus on empowering the VA to work more closely with community organizations to provide all the services that might help with a more public health approach to suicide prevention. So I think it's a really important signal in terms of recognizing that it goes far beyond just medical and mental health care in taking care of people and ensuring a high quality of life and focusing on the factors that help prevent suicide further upstream and empowering organizations that are already doing work in communities to not just providing those services individually, but especially coordinating those services across agencies, organizations, public sector, private sector, education, everything. So the grant program itself has been authorized for up to 174 million. So not quite the 150 billion that Michelle was just talking about, but a lot of money over 3 years to provide grants to communities to do this work. They can apply for up to $750,000 per year, and can be renewed year over year. And so I think we're, not only is that pretty significant of a development and really is the result of a lot of different community-based and national organizations and others really advocating and being on the same page for this approach being so important, but also, once again, I think leading the way in the veterans community for testing out these approaches and seeing how they work. And so what we know so far is just that timeline-wise, the notice of funding opportunity is likely to come in spring-ish of next year, with funding to be released later in the year. It's a lot of different types of entities are eligible, hub organizations, what we call coordination centers, other organizations, tribal communities, foundations, state and local governments could all be eligible, but there is such an emphasis on coordination, which is really, really important because not everyone can provide all the services that a veteran might need. It's being able to work with other existing services and stitch together something that's going to work to serve everyone, particularly underserved populations or places with limited access to services. So that's kind of about all we know at the moment, but we're keeping an eye closely on this grants program because it's just going to be such an interesting way to see how these approaches work and tie in. And it ties back to the rest of our conversation around, outside of just this, which is dedicated to the population that we're focused on, what else can we do? What else can we do to fit into some of these other even larger opportunities that are coming down? And so with that, I actually want to turn it back over to Megan for a second and say, now we're talking about all of this policy, these policy initiatives and trends, the possibility of additional public sector funding coming from really different agencies and supporting different groups. What do you see right now as the role of philanthropy in light of all of those developments and opportunities?
Yeah, so
I'm going to take the slides down so that we can see each other again.
I think philanthropy has an important role to play given the movement here. First, I think we have to be really careful not to create more confusion, right? These are going to have, as these networks roll out, whole and these policies sort of get enacted, whole of community impact, right? So again, we don't want a navigation network for older individuals, for veterans, for refugees and immigrants, for, I think it's really important that I think philanthropy can play an important role as sort of the connector in many communities. I think we play those kinds of roles. So being thoughtful about that as we grant make. I think there's a policy and advocacy role. As foundations, we're not allowed to lobby, but we're allowed to educate and inform. And it's so funny when we first made our grant to PACE to you all and to design PA Serves. I think way back when thought, my goodness, the holy grail is that the VA says navigation is important and that nonprofits and community organizations have a role to play to support veterans as they transition back into the community. And, the Hannon Act has sort of validated that and has really accomplished our original goal. But now I think we're in this moment of, and being so deep in the Pittsburgh community, it's important that that we're not siloing veterans and veteran organizations, right? We need our hospital systems to be asking about veteran status. We need our human services systems to be asking about veteran status. And I think that these coordination networks can play a really important role in getting someone who shows up at the front door of the human services system or in the emergency room of a hospital. Like, for example, if they're a veteran with a mental health or physical health issue, from the hospital, the private hospital, from the human services system to the best place of care for them, which at times, because of an income level or a service connection issue, is the VA. So I think philanthropy can advocate for that. And then the last thing I'll say is last mile cost. So we have such incredible nonprofits working in the Pittsburgh community, but to be honest, they're not all technology is tough to raise money for. And at times their systems are patchworked together and they're doing the best they can. They'd obviously rather invest in individuals than technology, but moving forward, technology is going to be such a huge and important part of these networks. So I think it's appropriate for philanthropy to take sort of a good look at our grantees, see what their capacity looks like and their ability to plug into navigation networks as they roll out, and try to equip them with the tech, the platforms, with the products, that be it an iPad or computer, so that they can log the work they do and the time they spend. And I think at some point it might be appropriate for philanthropy to start talking to hospital systems about sort of making sure that the nonprofits that serve vulnerable members of communities can connect to the hospital systems and vice versa. I think that's the role of philanthropy moving forward.
I think at least working with you in the past in Pittsburgh, we've seen it be really successful to drive conversations across some of those different entities, and it can be really valuable and enlightening what you find out about even just improving operations, let alone trying to build up the capacity of the individual organizations that are trying to participate in these things. I think you learn a lot even just by catalyzing those conversations. And so I think in addition to dollars and advocacy, just being the reason why people can get together and have some of these conversations, at least for us, has been really valuable. And so now I also want to go back to Michelle and ask we have a lot of groups on today that work in communities or in several communities. And I'm curious what you would, based on some of the recommendations from your report, maybe making some of those practical for this particular set of participants and for veterans serving collaboratives in particular.
So I'm going to sum up my advice actually with a Wayne Gretzky quote, which it surprises the heck out of people, but I grew up in high school in Pittsburgh. So I was a big Pittsburgh Penguins hockey fan during high school. And so I got to, gotta love Gretzky. So he said, skate to where the puck is going, right? And that's really my advice actually to talk to the groups here today, is that don't think about where the systems are today. Think about where the systems are going and begin to move there now. So that for me means I think that any veteran serving organizations who are doing navigation need to have conversations with their hospital systems and with their healthcare systems, because they have a navigation network, and chances are their navigation network has no clue what is available for veterans in your area. They are going to address everybody as if they are just a civilian population. And we know that there are some really great resources for veterans if they will just identify them and make referrals there. So start that conversation. The second piece is, I think we don't need just as a group to be interested in VA policy, although that's important. I think you have to be aware of these conversations about what's going on in CMS, what's going on with the Linked Act. And veteran organizations need to be a part of the advocacy around shaping these programs, because right now they're treating them as separate funding streams, right? Like there's one system that's going to just work for veterans and one system for everyone else. And we know that many veterans don't go through the VA system. They go through a private hospital, or they go to their local human service agency. They don't start with a veteran serving organization. So figuring out how to do more advocacy work together around these policies is really important. And the last piece, and this is another piece around where the puck is going, is think about your metrics, right? You know that the puck is moving towards the ability to show social impact. So you need to design data systems today that will set you up to be able to say, does navigation provide a reduction in cost for healthcare services? Does the navigation that you've provided demonstrate greater wellness for clients as a result? Do you have more concurrent needs met as a result of those pieces? You need to have data systems that will let you get there. Once these acts and these policies come into full implementation, my worry is it'll be too late. So start now.
Megan, Nick, anything you would add advice-wise based on some of that?
I'm deferring to you, Nick, but I have nothing to add. I appreciate what Michelle just said. I think she covered it.
Same. I think there's a lot of good questions too. So
Yeah, we can get to turn to questions. I think I just want to add that on the data side, I think the way that IVMF is starting to think about it, if helpful, is that there's a lot that can be done on the data side, even as technology remains interoperable. And so one of our highest priorities is to focus on how we can make more apples to apples comparisons with the data that everyone is collecting, because we don't have to wait for federal standards for interoperability protocols on the front end with technology in order to start defining, building on what definitions exist and are common across all of the different populations that are being served, that are tied more to what the social determinants of health are and how people have defined successful outcomes in those areas. And so that's kind of what we've been focusing on and think is really important while a lot of this, while the puck is still moving. So I think to start on questions, one thing we got ahead of time that I think could be helpful, because we've talked a little bit about health systems, technology, organizations, what the role of states, and we did talk about states with Medicaid, but specifically with setting up collaboratives or their role in facilitating collaboratives. What do we think that states can do to, because there are some states like North Carolina, for example, that have had really strong investment at the state level for a long time in community-based and state level coordinated care. What can other states do, or what lessons should they take from those efforts? And I'll let anyone jump in here.
I would like to see states do at least two things, and then maybe Megan and Nick have other things they'd like states to do. One of them is that if you're going to apply for the Medicaid 1115 waiver, which is the only way to kind of do these financial systems right now, that has to be at a state level decision. That's where that rests. And so states need to decide they're going to do that and to apply for that waiver and to talk about how they're going to develop referral systems. So that's one piece. I think states can also develop and establish interoperability standards for these different navigation networks that are being rolled out at hospitals and community service organizations. There's some lovely Creative Commons licensed API standards that are out there. Better standards are being developed right now by the Gravity Project. So states can go ahead and invest in those standards in order to be able to access the financial resources that would be available through a waiver. And in doing so, they can really move the navigation systems in their state forward. I don't know that you have to buy a common platform for a state, but some states are considering that. Pennsylvania's gone back and forth on that a little bit. Then they chose one and then they unchose it. And so that's a role a state can play. What it does simplify some pieces if you choose to do one common system, including being able to have one common resource directory built out for everybody. But that it does have some downsides too, because those systems may or may not be interoperable with the ones already being used by human service providers or hospitals.
I just piggyback on that, Michelle, and say I think the federal data standards around networks have not been established, and so I know a lot of states. I think Pennsylvania is one of them that is sort of waiting and nervous about heading in one direction to be then told you're supposed to be going in a different. I do though think we know enough to have complicated, hard questions about navigation, and we do understand, what you laid out in your report, the types of networks, the functions of networks, how people show up in networks or don't in others, what an open loop referral is, meaning, here's the number, call it, good luck to you, versus a closed loop. We know you got to the resource that you asked for, and we know how long it took you. I think they're hard, and I've seen in Pennsylvania, they become political conversations, and really they shouldn't be. It should be about what's going to lead to the best outcomes. And although I think the science around networks, and I'm not the one to speak to, this is you, Michelle, probably more than anybody, hasn't been able to deliver at this point or quite yet, right? That, a closed loop referral system saves X dollars versus an open loop referral system. But there's enough anecdotal evidence at this point to sort of, I think, for a state to decide, these are some of the standards or the minimums. And one, as an example, not being the scientist here, but is that closed loop referrals are something that our networks must have. So, and I think and I think just like, what we talked about philanthropy being a convener, the state can be a convener too. There's competitiveness, there are health systems, there are different foundations doing different things, there are county governments doing things, there are departments in Pennsylvania that are creating their own different navigation networks just at the Pennsylvania sort of state level. They can be conveners on this topic.
I also think that and this ties into another question that came in around subpopulations, and as we try to get more alignment or not create confusion in the marketplace of all of these different systems, how do we preserve the ability to take care of the needs of particular subpopulations as we do this? And I think one thing is states have the ability, I think, to make sure that that's happening. But are there other ways that, especially even going back to some of the ways that these systems are designed, where you have the human navigator element, or you have the community connection type that tend to be less tech focused and more person focused? What are the ways that maybe we can bring those into these bigger system design conversations? And what are the possible risks of doing that, other than, I would think, cost, that they would be a big cost driver? But I don't know, Michelle, if you have any thoughts on how to balance those competing needs of vulnerable populations and not wanting to create confusion.
Mm-hmm. I think that it's important to have two pieces. The technology needs to align, right? So that you can, I think, get to greater accountability, in part, to make sure that people are receiving the services that when they request them from different agencies. I think you do need that. For any population who has been marginalized, minoritized, or has experienced trauma, I think that human navigators, especially trauma-informed human navigators, are key. And I think investing and developing models around paying those human navigators to support individuals through a help-seeking process that are in those categories in particular is an important policy area that hasn't been fully discussed at this point. In terms of the veteran population, I really think that you need a person there, especially for veterans who have concurrent needs or have really challenging circumstances. It's not enough to point them to a technology system and say, go search for it, good luck, you can make your request right there. You need a person who can check in and can talk to them and can do an informal screening and figure out what's going on and develop a plan around what to move forward. So for me, that means investing in individuals who can make those types of navigations. They're often individuals who've had experience with the population. That from my husband is a vet, and I will say there's nothing like a vet talking to a vet, right? Whenever they're trying to walk through services like that, that really is valuable. And I think the same is true with other marginalized and minoritized groups who've experienced trauma. So that I think investing in the human navigator side is especially important in those circumstances.
I think for a lot of us that have been doing the work for a long time, it might be helpful to I'm going to keep going back to the puck analogy here, but if if we have to start thinking about where these systems are going, it may require rethinking how we currently think about coordinating care in communities where, you know, I think a lot of communities, whether it's really formal or not, have those go-to organizations. Again, whether they're using technology or not, whether that's the county VSO, whether it's a full-blown, you know, care coordination operation, people sort of know where to start, and that's really valuable. But in these bigger systems, it might be worth trying to reimagine what that is going to look like as things move forward and fitting into these bigger systems. And I think that's still an open question of what it's going to look like, but it's something to start thinking about. I think particularly if you are one of those full-blown operations, you know, figuring out how that work and what you do as an organization fits into these bigger picture conversations. It may be that, you know, and I know a lot of people have been creative already in partnering with VAs in how to do that within the veteran part of the healthcare system, but thinking even bigger than that is going to become even more important, or it seems like it's going to. Another great question that we got is, you know, a lot of people, so for people who are just starting out thinking about this work or have been having a lot of conversations about how to organize, you know, services for veterans and their families, and now are facing even bigger challenges than that with all this other stuff going on. Is there a roadmap or a place to start with trying to understand, I mean, other than Michelle's report, which I can't recommend enough, any other good resources or places that you would recommend for people who are trying, like us, to get smarter on this topic? And I'm thinking too, because I'm trying to remember like what I've read recently.
On the referral platform piece, there's a group out of University of California at San Francisco called Siren, SIREN. And Yuri Carter published a report a couple of years ago that reviewed all of the community referral platforms, including what their features were, whether they closed loop or not, and what screeners they were using for social determinants of health. And that's a really great resource to get smarter about the platforms and the technology features. I'd highly recommend that. Yuri Carter. So we can put a link to that. There we go. And then the second thing I would say that would be potentially helpful is to spend some time learning more about community health workers. There's a lovely set of literatures, and we can afterwards, I'm happy to look up some links and send them out to your list of attendees around what's needed in order for community health workers to be effective. I think that's a nice piece around human navigators. And particularly as you think about what kind of training community health workers would need in order to be able to deal with HIPAA information, for example. We could think a little bit more about what kind of systems would need to support those workers. And that would be a second kind of reading set that I would take a look at.
One other trend we've been reading about that we can see if we can dig up some stuff on, it's just that there are developments around studying what this whole industry, we just found a recent article about this, the whole social determinants of health industry is starting to look like. And so it's, as far as academic articles go, it's reasonably digestible. So maybe that's one we can share also. And the reason I bring it up is because what we're seeing is a lot of focus on this topic from the community perspective, or the perspective of a community-based organization, or in our, you know, in our work, we might just say a VSO, because as you know, Michelle talked about in the policy part of this, and in general, we've talked about healthcare, whoever is driving these conversations, it's often not communities, because that's not where the funding always is. And so I think more and more, it's important to think about that side of it, and to ensure that it underscores the need for, I think, our sector to try to follow these trends and ensure we're aligned, because I think the alignment that we've had thus far is the reason, for example, that the Hannon Act exists today. And I think that we need to ask ourselves, what's the next priority that we have? Is it, for example, as Megan was talking about, ensuring that all of these systems are asking about military status? Are there other subpopulations that we might want to work with that have similar needs that are around attributes of those subpopulations, and that we're advocating to collect that kind of information during the screening process so that people can get efficiently, the ones that really need to get to those human navigators are getting there, because at the outset of your conversations, you're identifying them up front. I know that's also a huge focus of a lot of the Governor's Challenge groups, and I know there are a lot of participants on today from some of those Governor's Challenge groups. And identifying veterans depends on far more than just our own community to do that. So that's just one example, I think, of a conversation that we collectively need to be working toward. I know, Megan, you're nodding because you've been thinking about this quite a lot also. Is there anything you want to add?
I just anecdotally, layman's term, I've been seeing for a while, I feel like the veteran service sector really is ahead on forming and operating these networks. And we have a lot of years of sort of under our belts of it. And honestly, we have a lot of data too, I think. But on the other side, perhaps the Health and Human Services sector, the department, right, is ahead of us on the academic parts or the data standards of this. And so I think it's on I think there's a shift happening right now where it's not about the individual veteran network that you're most connected to or close to. It's less about that, and it's more about what does our sector need to do? How do we need to come together to make sure that the larger systems, the broader systems, the community systems know how to identify and connect veterans? Because I think we in Pittsburgh in the veteran service sector are likely reaching and touching on a daily, annual basis less veterans than everyone else is. And so how do we, sometimes the broader community is the right place to refer a veteran, and then other times, a community organization is seeing a veteran and then they need to kick them over to the VSO sector. And so I think this is a conversation we need to sort of get in the middle of.
One question just came in about whether there are states that serve as best case examples. And I know, Michelle, you've looked a little bit at California, and I always forget the other state. Do you want to share those really quickly? And then maybe we can do one more question.
So California and North Carolina are probably the states who have invested most. They have a longstanding Medicaid waiver and have been moving money. And so if you're going to look for case studies, that's where I would start. There's other states who have also done this, but they haven't received as much attention as California and North Carolina have for their efforts.
I think right now, I'm not sure I would say that there's a perfect use case for how the veteran side of things is being folded in. I think a lot of things are being tried, including in North Carolina right now, and it kind of remains to be seen what the best practices are as a result of some of those. I mean, there are some that have been identified all along, but I think a lot of this is being sorted out, especially, I know we have a bunch of people on from North Carolina right now where the veteran serving collaboratives and networks there, the formal ones, predated the state's efforts to make something bigger associated with Medicaid or for all people. And I think merging that together is teaching us a lot. And I expect over the next few years for there to be a lot more coming out of North Carolina, especially about this topic, as opposed to only the funding side of things, because I think we're still figuring out how the veteran piece of this fits into, some of those funding models. And so I think North Carolina is a good test case for that at a minimum. Okay, so we're almost at time. The one question I didn't really get to that I think maybe we sort of, I just want to address it really quick. was asking sort of like how to think about when you're designing something from the ground up, like what are the considerations? And I think that Michelle, your report does I just want to, I know I'm like plugging it like crazy, but I think it does a really good job of laying out what the kind of pros and cons of each approach are, given what your community or the population you're trying to serve really needs. So I would encourage that as a starting place. And then I'm going to pull up, just while we end, all of our contact information, because those are the types of questions that I know we would all be happy to talk about further. And I'm very, very grateful for all of the chat here, because we'll go back and look at it and make sure that we sum everything up in the in our follow-up note to everybody. But with that, I'm going to turn it over to Nick to close us out.
Sure. I just want to just echo Gilly in my thanks to Michelle and Megan for spending an hour with us, and for our guests for tuning in. Clearly, all the engagement and the questions, I think we might want to think about maybe a part 2 to this in the new year. A lot of attention both in the marketplace and in policy as legislation is in the queue, as Michelle highlighted. So we're really excited. You can see our contact information is here. If you've got any follow-ups, we'll certainly be pushing all this content out to you who've signed up through our listserv. So look forward to engaging with you all in the new year, and wish you all a safe and happy holidays. Thanks very much.